I'm going to start with my presentation. It's an overview on the concept of forced displacement. And hopefully, by the time I'm done, we have a bit of a technical issue downloading the other presentations. So hopefully by the time I'm done, they will be ready. As Professor Batanza mentioned earlier, forced displacement is a huge problem. Before I go ahead with my presentation, this work is part of a teamwork. We have a much bigger team, and I am really privileged to be working with this team. Professor Batanza and Professor Baldacchino, the president of the ISAM, are leading that team. And we had been working on that topic for the past couple of years. We have many stakeholders and important, like very big names involved in this project. I have no financial conflicts to declare. As a start, imagine that the blue square is a country and the green square is another country. And you have people living somewhere in that country, and unfortunately, they are exposed to something terrible. It could be a natural disaster, it could be a war, it could be toxins, whatever, like something major happens around them. And because of that, they have no other option except to leave where they live. So they will move somewhere. It could be within their own country, and in that situation, they will be called internally displaced people or population, or they will have to move to a different country and face whatever they will face there. So basically the definition of forced displacement is a coerced or involuntary movement of people from their homes, often due to a generalized violence, armed conflict, war, violations of human rights, politically or ethnically motivated persecution, and or environmental disasters, to allocation either within their own countries, internally displaced, or another country, whether they can relocate there, whether they will get a refugee status, or whether they will face problems there. They have to deal with that when they move. In order to understand more, in mid-2021, more than 84 million people were displaced worldwide. 48 million of them were internally displaced. They had to move somewhere within their own country. 26.6 million were refugees. 4.4 million were asylum seekers. And that's mid-2021. So I guess we're almost a year now. The updated statistics will show higher numbers. So I think the number is now 85 million or something like that. And sadly, 42% of all forcibly displaced people are children. To understand more what's meant by forced displacement, imagine that you live in a safe environment, live in your own country, in a safe area. And in that area, you have the goods and bads. You have risk factors for certain problems, certain illnesses, but you might have other supportive or protective factors in your home environment. And suddenly something happens, and you have to face the acute displacement phase. Volcanic eruption, tsunami, war, and then you will have to move. And while moving, this is called the transition phase, and you have to deal with the problems you face moving to the new area. And you go to a host country, which might be accommodating, which might not be accommodating. You don't know what will happen when you go there, and you can either resettle there, you can ask for a refugee status, and again, it could be a country where they are supportive for refugees, or they keep them in camps and they face a lot of atrocities there. Or you get deported back to a country where you are already fleeing from, or things go well and you decide to return to your own country when things are better there. So forcibly displaced people have often been exposed to or have witnessed significant violence and abuse and experienced homelessness, loss of belonging, separation from family and friends, social and economic hardships, poor nutrition and lack of health care in their country of origin, and during transit and on resettlement. And the consequent trauma responses and mental health disorders, discrimination and stigma, and the acculturative stress, all the stresses they have to face generate vulnerabilities, they act as risk factors, and unfortunately the needs that are generated are not always like supported or there is not enough support to face those needs. Why did we decide to focus on substance abuse and forced displacement? Where is the link? So we all know that substance use disorders are characterized by continued use of drugs or alcohol despite important substance-related health and social problems. Usually this is prevalent among groups or individuals facing multiple vulnerabilities, interacting at individual, community, and societal levels. And my colleague, Dr. Jotei, will elaborate more on that concept when he uses a syndemic lens explaining substance use and forced displacement. Also, the risk factors associated with substance use disorder are similar to or overlap with those experienced by forcibly displaced people. They have, when you look at the risk factors for people who develop substance use disorders and compare them to the risk factors or the things that people who are forcibly displaced are put under or through, there are a lot of similarities. According to the WHO, substance use disorder accounts for approximately 338,000 deaths in 2019. And this is only related, like this number is directly related to the disorder, so the mortality is expected to be higher than this. And for people who are forcibly displaced, the consequences from substance use disorders are expected to be more evident because they don't have access to a proper healthcare system. They are facing more health issues, they are facing stigma, they are facing other things that makes it very difficult addressing the problem. And moreover, 4 out of every 5 forcibly displaced people are hosted in low and middle income countries, with 76% experiencing prolonged periods of displacement more than 5 years. Which means, because the country is already lower or middle income, they don't have the facilities or the infrastructure or the finance to support people who are forcibly displaced there. To make things a bit clearer and to conclude my presentation, let's imagine what happens in each of the phases. So before displacement, if you need to look at the substance use disorder epidemiology in the country of origin, you need to look at cultural issues. Some countries might have less substance use disorders when it comes to certain substances because of cultural issues, or have more of them because these drugs are, you can even go and say, endemic. And I think that's something Professor Habibi, we were discussing a few years ago in Lisbon conference regarding tramadol in Egypt. And health service status, do we have enough support? And individual factors related to those persons who get displaced. Then the acute displacement phase, they have the stress of dealing with the disaster itself. They have the painful emotions that comes with the experience, with the loss they face, the grief they have to deal with, the trauma they are experiencing. They might even develop, or they are in early stages of developing something like PTSD, they might start using painkillers or anxiolytics to deal with the problem, or stimulants to be able to travel like hundreds of miles or thousands of miles in a small boat to reach another country, and they have to stay awake, otherwise they will just fall asleep and fall off the boat and die. And then the transition phase, while they are being transported, as I mentioned, they might use drugs to support them, or they might get exposed to drugs during the process. When they are in some camps, they might also be exposed to new drugs they are not familiar with in their own countries. And this is something that when we were working on the project, it really saddened me reading about it. And I think we discussed this a little bit because some of the experts involved had real field experience. And they highlighted how drugs and sexual abuse were used in return, like to return favors to people who are in camps, like to give them more food for their kids, and they provide them with drugs and ask them for sexual favors and so on. So the camps are, in general, most of them are very good and supportive, but some other horrible things happen there. Acculturation stress, you need to deal with a different culture, a new culture, and start learning things and adapt to new things. As I mentioned, new drugs and self-medication to deal with the stress. Again, in host countries, they have to deal with the acculturation stress, access to new drugs, loneliness and hopelessness. We think many of us are familiar with what happened to forcibly displaced people we came across, where they have left all their families and they ended up being on their own in a foreign country, or they got separated from their kids or other family members, and they are completely alone in a different culture that they know nothing about. Again, self-medication, and at this stage, you can expect that mental health issues that had been developing through the process start emerging, like PTSD. Stigma and discrimination, they have to face racism, they have to face how people will look at them, and if, as refugees, they will always be treated differently. And when they resettle and get housed somewhere, they will continue to be treated differently. Or, as the problem with drugs in general, it could be something out of fun and curiosity, like, maybe now I have access to something that I never had access to, why not to try it? Then, as I mentioned earlier, they either get deported, they have to go back to the country of origin where they had to face a problem, or they start the displacement phase again and try to find somewhere else, and the cycle keeps going on and on. Or things go well and they end up returning to their countries when things are much better there. This diagram, I'm not going to take credit with it. It was also part of our teamwork. We tried to summarize the whole process, and I hope this had shed some light on the problem of forced displacement and the problem substance use disorder, and makes things easier to follow up with the following presentations. Thank you for your attention.
Should we take some questions? Okay. So first of all, I would like to thank Professor Elkholy, Assistant Professor Elkholy, for a wonderful background, as well as for taking the lead along with Dr. Joe Tay on this manuscript that has been developed over the past couple of years that covers this important topic, and hopefully that will be available for the public soon. But I think this lays the groundwork for the next presentation from Dr. Joe Tay, and maybe we'll take questions afterwards when we have the discussion, who will be presenting on a syndemic approach to substance use disorders in forcibly displaced populations. We can do that? Yes. Okay, that sounds great. So we're having a little switch in the program. So we're first going to hear from Dr. Anja Busse, who will be talking about recommendations and future directions for substance use disorders in forcibly displaced populations. As a reminder, she is from the UN Office on Drugs and Crime in the Prevention, Treatment, and Rehabilitation section in Vienna, Austria. So she will be giving a taped presentation that I think will be very informative.
Very much for having us. It's a pleasure to be here with you today. Unfortunately, only remotely. Let me start bringing up my slides. My name is Anja Busse, and I work with the UNODC, United Nations Office on Drugs and Crime, with our Prevention, Treatment, and Rehabilitation section. And I will speak to you today on a topic that's unfortunately becoming much more relevant also in our daily work: substance use disorders in humanitarian settings and situations of displacement. And what I will show to you is a little bit of preview of the considerations behind an upcoming handbook of UNODC and our partners UNHCR and WHO on the topic. So humanitarian emergencies, one could define as an event or a series of events that represents a critical threat to the health, safety, security, or well-being of a larger group of people, and that usually covers a wider geographical area. And there is a growing need to reflect substance use disorders also in humanitarian settings, including because the prevalence rates in countries where displacement takes place or that turned really into humanitarian settings are rather high in some situations, and there has been kind of previous attention by UNODC, including, and now we also see how we have to adjust our support to countries and people in humanitarian settings. This is kind of from a previous World Drug Report showcasing different risk and protective factors for substance use in general. But if you see in red the risk factors for substance use, those include here poverty, conflict, war, homelessness, refugee status, but also mental health and trauma, social exclusion and inequalities. So a lot of factors that disproportionately would affect people in displacement or in humanitarian settings. As we go on, I just want to say that we should not forget that also protective factors, even in such situations, can be strengthened, and my colleagues that work more on prevention of drug use have done amazing work working with families and children in humanitarian settings in different parts of the world. This presentation, though, will focus more on substance use disorder treatment. So what do we know and what we don't know? I mean, we do know how many people worldwide use drugs and how many people worldwide are in need of humanitarian assistance. So, for example, there are roughly 36.7 million people globally who suffer from drug dependence and would benefit from drug treatment. And roughly 5.6% of the global adult population has used an internationally controlled substance during 2020. We also do know that around 274 million people are projected to need humanitarian assistance in 2022, and that close to 90 million people were forcibly displaced in 2021. What we do not know so well is how these two groups overlap, but from available studies and data it was found that displaced populations showed similar or lower prevalence rates compared to host communities, despite this likely increased vulnerabilities such as those we have just looked at. The global situation when it comes to access to drug use disorder treatment in general is already a scandal in itself. Only 1 in 8 people in the general kind of community, not thinking humanitarian settings, have access to any form of drug use disorder treatment. And there is now a policy mandate to address substance use disorders among vulnerable members of society, which we have both from the General Assembly that kind of spoke in the special session on the World Drug Problem to the needs of vulnerable members of society, and the Commission on Narcotic Drugs in 2018 also kind of specified the need to provide for vulnerable members of society in response to the world drug problem, and very much refugees and people in humanitarian settings would be kind of vulnerable members in this sense. There is also a previous resolution by the Economic and Social Council of the United Nations from 2004, mainly on countries emerging from conflict, that gave a strong mandate to UNODC to mainstream in our drug control programs the development efforts of countries emerging from conflict, and urging such countries to give priority to addressing drug problems and work with UNODC on such in post-conflict situations. In 2009, UNODC and WHO launched our interagency program on drug dependence treatment and care, and addressing drug use and associated health and social consequences in relief and humanitarian settings was already then among the priorities. And when we launched the international standards for the treatment of substance use disorders in 2020, those for you who are not familiar with them provide a continuum of care from outreach to outpatient, inpatient, longer-term residential services, and describe evidence-based interventions that can be implemented in such settings. But the question really was how to adjust the treatment standards to humanitarian settings. So we had to do a little bit of learning, and one of the things that can be learned is how humanitarian emergencies are kind of differentiated among what the drivers, like are they natural or conflict driven, where do they take place, in camps, in urban settings, in sometimes inaccessible situations. In which phase of a humanitarian emergency are we in an acute phase? Is there a slow onset? Is there in a protracted phase? And interventions, kind of including substance use treatment interventions, need to be adjusted to these different phases. As said, humanitarian emergencies and displacement are much interlinked, and substance use can take place anywhere from places of origin, kind of to transit, to temporary refuge or resettlement, and kind of comes with unique considerations that need to be addressed when looking kind of at the place, the setting, the driver of the emergency, and the phase. It's also good to know who are normally the humanitarian actors, and that communication among humanitarian actors is absolute key. And traditionally, kind of responders in such situations are UN agencies, but also the Red Cross and the Red Crescent movements, very experienced non-governmental organizations. There's also a responsibility kind of among governments where this takes place, and there is need, of course, for a solidarity of the international community as such. The Interagency Standing Committee is kind of the oldest coordination group or coordination body that brings together both UN agencies and non-governmental actors in coordinating a fast and efficient response to humanitarian settings. And we as UNODC participate in the mental health and psychosocial group of the IASC, and we really see our role in advocating for substance use disorder treatment not to be forgotten in the overall responses and in the mental health responses. Humanitarian action often takes place in these kind of type of clusters at country level. Depends a little bit, but what we are seeing that the health cluster very much is where support, including substance use disorder treatment support, has been facilitated and coordinated including in current emergencies, but we're also seeing the need to mainstream kind of in the other clusters and, for example, advocate with actors such as the World Food Program to kind of adjust their routes in a way that places where treatment centers are or where people with substance use disorders are and service providers are also benefit from food supply, so that it becomes really mainstreamed and we ensure nobody is left behind. Humanitarian action kind of is guided by these principles: humanity, neutrality, impartiality, and independence. And substance use disorder treatment in humanitarian settings obviously also needs to follow these principles. If you come back kind of to the international standards for treatment of drug use disorders, where we are thinking how to adjust those to humanitarian settings, just to be reminded that those provide guidance at the treatment service level, where across different settings, such as community-based outreach, non-specialized settings, specialized outpatient and inpatient settings, and long-term residential settings, they provide guidance how to implement evidence-based psychosocial and pharmacological interventions kind of in general. They are not adjusted to humanitarian settings. They also provide guidance on the development of public health informed drug treatment systems, where we hope already to provide the most effective, least costly, and least invasive service with the priority, and therefore the base really needs to be where outpatient treatment takes place in such a system. When we come now to humanitarian settings, there is a similar pyramid, but specialized services in general are much more on top of the pyramid, and kind of activating community support and non-specialized supports kind of even takes more of the pyramid. And the Sphere Handbook, which is kind of an agreed upon guidance for humanitarian settings, has set a number of health standards that are important to know, and they detail, for example, health service delivery, healthcare workforce, access to essential medicines and medical devices, health financing, and health information. All of this, of course, also relevant for the provision of substance use disorder treatment in humanitarian settings. In the Sphere Handbook, there is attention to mental health care standards, and in those, as you can see here, number 8 is also attention to minimizing harm related to alcohol and drug use, to train staff in the detection, brief interventions, and the management kind of withdrawal and intoxication from substance use. So then UNODC, with our partners, we got to work and working in this area, and where we started is with rapid assessments to better understand the situation with substance use, but also the availability of services. And we conducted 2 assessments, initially one in Uganda and one in Pakistan. In 2020, we then hosted a big expert group meeting with over 100 humanitarian actors, drug treatment experts, experts nominated by interested governments. And following that, we did a resource mapping on guidance available, such as the MHGAP tools from WHO and others, kind of what's available, what can be adjusted to substance use treatment in such settings. We did a further Delphi interviews, kind of a Delphi process in reality with humanitarian actors to understand priorities and needs. And we coordinated in real-world emergencies and with bodies such as the Interagency Standing Committee on this topic. So with our partners, UNODC, UNHCR, WHO, we want to together launch a handbook on addressing substance use disorders in humanitarian settings that will be structured around these phases: assessment, preparation, delivery, monitoring, and evaluation. In the assessment phase, a recommended emphasis will be on rapid participatory approaches and, where possible, to integrate substance use and other assessments of health or social needs. And as you can see here, there are a number kind of assessment tools that are relevant and can be adjusted, should be considered. Especially, I'd like to recommend the UNHCR WHO tool on rapid assessments for alcohol and substance use in conflict-affected and displaced populations. This handbook we have also used, and here is as an example our Uganda report that was just launched. And one of the findings there was the need to really strengthen the global, the country level response and capacity when it comes to substance use disorder treatment, and how that would also benefit kind of the displaced populations that Uganda is kindly hosting in numbers. In the preparation phase in our handbook, we will speak very much about the need to coordinate and kind of obvious things such as the identification of local partners, making local agreements, financing of services, identifying and training human resources, adjusting tools, ensuring access and procurement of medication, safety considerations for service users and service providers and others. The preparation phase should be guided by these principles to be integrated, inclusive, intersectorial, interlayered, and as such implementable, and really needs to bring together the kind of humanitarian service provision pyramid and the service provision pyramid from the international standards for treatment of drug use disorders. And therefore, when we go in the deliver phase, after an assessment and preparation is done, we differentiate between acute emergencies, where a focus will be on reducing excess morbidity and mortality, and considerations to the unique features of substance use disorders, including among displaced populations where, for example, a sudden interruption kind of patterns of substance use or the availability of substances can be associated with life-threatening withdrawal, or kind of a change to more risky routes of administration might lead to an increased risk for overdose. So those very much need to be looked at in an acute emergency, and what we will be recommending includes screening, brief interventions. Referral to treatment might be very difficult in reality. Also withdrawal management, reduction of negative health and social consequences and services for such, having kind of an emphasis on continuation of medication as possible, and also basic psychosocial support, access to self-help, and remote counseling. And delivery in a protracted situation will be more on integrated care, will be all of what we said before, but kind of become closer to normal community-based drug treatment in low resource settings, because there will be just more time, even though not much more resources, and still special challenges. Challenges such as those that there will be competing priorities, other health disorders, resource constraints, definitely a lack kind of to access to specialists for training, where to refer to consult with. There might be, due to volatile situations, disruptions in the supply of medications, in staffing, there will be population mobility, and a lot of things to be addressed in both acute and protracted emergencies, but maybe on different scales. In the evaluation phase, also to differentiate maybe what's possible in an acute and a protracted emergency. In the acute emergency, kind of emphasis on a basic set of feasible process and outcome indicators and this principle to do no harm. And in a protracted emergency, there will be more space kind of to also set up routine monitoring and surveillance systems. And I really like to bring your attention to the key indicators from the Sphere handbook on monitoring and evaluation. So what we will do in our handbook and for field testing afterwards is a potential package of interventions or of tools that are already existing to not reinvent the wheel for all phases: assessment, preparation, implementation, and evaluation. And these are tools that you have seen here before on the screen. I especially would like to highlight the UNHCR WHO Rapid Assessment Tool that we have also used, and the WHO MHGAP Humanitarian Package. So that is kind of mental health and psychosocial interventions integrated and already adjusted to humanitarian settings, or more specialized could, for example, be the UNODC treatment training package that also provides basic training in more or less 2 weeks on substance use disorder treatment. But we will need much more research and information, and we are mainly calling out for implementation and feasibility studies, such as through the field testing package that we've just said, and the setup of a global network where we can share information and build jointly our expertise in this area. On the policy and advocacy level, it's always important kind of that countries, host countries, have kind of a responsibility to provide protection and support, that we need to mainstream the attention to substance use disorders in humanitarian settings and in displacement throughout, implement kind of these 5 I's, kind of the intersectorial, integrated, inclusive and interlayered approach to make services implementable, and really make our best efforts to coordinate with other actors. So our guidance will be soon published, and we hope it's going to be useful for you, that you help us in reviewing it, in field testing it. And with this, I'm coming to an end of my presentation, and I would like to thank you very much for your attention. Please reach out, please be in contact, and let us know what we can learn from you on addressing substance use disorders in humanitarian settings. Thank you very much for your attention. I wish you a good conference. Bye-bye.
Thank you very much. Please send our regards to Anja. It's a very comprehensive and nice presentation and informative. And for my colleagues here to know why is this important for not for the international part, but also for the local and the regional part. Egypt now is having 273 refugees in Egypt. According to the UNHCR latest statistics, we are having 9 million migrants. So we will see people that are these vulnerable groups that are being discussed. They will see it in our local and our regional area a lot, and that's why we need to know how to deal with them, because as I told you before, they have special needs, very special needs, and this was really very well presented by Anja in her presentation, and Dr. Hussain as well, Dr. Elkholy as well. And to take a closer look before we see and listen to the last presentation today, and I open the floor for questions. When I was in Yala, South Darfur, in the camps there for the internally displaced, we found we had this humanitarian mission, and we were doing the assessment as a study assessment that was published in the International Journal of Social Psychiatry. We were assessing the psychiatric comorbidities, and we found people having substance use, and we had ladies that are having alcoholism. Although alcohol was prohibited there were very strict measures against alcohol. So they manufactured alcohol by local means in the camps, and they drank it with all the consequences of this unusual way of producing and consuming substance. That's how they are. Sometimes they do it and they are keen for it because they suffer a lot, and for many reasons, not just as Dr. Elkholy said, or even to stay awake to protect themselves, or even to sleep, because sleeping in a camp is not an easy job. They just wanted, when we asked the lady, why were the reasons for doing it, she said, I want to sleep, I can't sleep. That's why it's a very important, and thank you again all for it, and we will face it. It's not that distant, it's not just related to international organizations. No, it's really related to every mental health professional that's working in the field. So please, would you please present the last presentation?
Yes, thank you. Thank you for the words of wisdom, and also thank you to Dr. Busse for her wonderful presentation. The final presentation is by Dr. Joe Tay, who is co-leading the Lancet Psychiatry manuscript effort with Dr. Elkholy. Dr. Tay will be presenting on its endemic approach to substance use disorders in forcibly displaced populations.
Good afternoon. I'm tremendously pleased to be able to present to you today on the topic of endemic approaches to understanding substance use disorder among forcibly displaced populations. My name is Joe Tay. I'm Clinical Services. Good afternoon. I'm tremendously pleased to be able to present to you today on the topic of endemic approaches to Good afternoon. I'm tremendously pleased to be able to present to you today on the topic of syndemic approaches to understanding substance use disorder among forcibly displaced populations. My name is Joe Tay. I'm Clinical Services Director for Forward Leads in the UK and an Honorary Research Fellow at St Andrews University. So what are syndemics? A quote from Amelia Lane: "If the era of COVID-19 taught us anything, it's the importance of viewing health and socioeconomic factors as mutually reinforcing. The past years have highlighted how health crises are not only biomedical phenomenon, but intrinsically encompassing political, social, cultural, and economic dimensions." Syndemics are defined as synergistically interacting epidemics that occur in a particular context with shared drivers. Basically, when a policymaker asks why some communities have higher death rates from drug overdoses compared to other communities, a syndemic approach argues that multiple factors work in tandem and populations with the highest morbidity and mortality experience the greatest impact of these interactions. This diagram attempts to describe what a syndemic relationship is. On the left, in green, you see that there are strong interactions between disease A and disease B, both of which occur within the same population at the same time in the same geographic location. Contextual factors affecting the population, which can include social, economic, and geographical factors, all impact upon this interaction between the two diseases, making their impact more severe. On the right, you can see in red where there is no real strong relationship between disease A or disease B, and contextual factors, if anything, might actually mitigate against these diseases, producing a severe effect in that population. Hence, no syndemic relationship on the right side. The syndemic approach is certainly one of the moment, even though it has, of course, been around for some time. We can see here from recent publications that it is being used increasingly, for example, in complex humanitarian emergencies, looking at substance use among urban refugee youth, also looking at comorbid diabetes and obesity amongst immigrants and refugees. Looking now at what forced displacement is, forced displacement is defined as the coerced and involuntary movement of people from their homes, often due to generalized violence, armed conflict or war, human rights violations, politically or ethnically motivated persecution, environmental or natural disasters, to a location within their own country, called internal displacement, or to another country, where some may be entitled to refugee status. Mid-2021, there were more than 84 million people displaced worldwide, of which 48 million were internally displaced, 26.6 were refugees, and 4.4 million were asylum seekers. Forced displacement continues to rise annually to unprecedented levels. So what is the nature of substance use disorder amongst forcibly displaced populations? I don't need to define substance use disorder to this audience. The continued use of alcohol or drugs despite important substance-related health and social problems. We know that substance use disorder is more prevalent among groups or individuals facing multiple vulnerabilities which interact at individual, community, and societal levels. We also know that these same vulnerabilities associated with substance use disorder also overlap with those experienced by forcibly displaced populations. Yet there is significant heterogeneity in patterns and prevalence of substance use across the different forcibly displaced groups. For example, amongst people who have been displaced, with regards to alcohol use disorder, prevalence can range from 4 to 42% in camp settings and to less than 5% in community settings. When looking at a walk-in center for forced migrants in Germany for substance use disorder, 17.4% prevalence was identified. However, in contrast, a study of Syrian refugees in Lebanon showed a low prevalence of substance use disorder of less than 0.1%. A simple way of looking at one of the reasons why there might be so much heterogeneity is the incidence of substance use disorder in an individual or population will have at least something to do with cultural or subcultural patterns of use by age, gender, ethnic, and religious affiliation in the person's community of origin, and equally, it is highly dependent on the similar patterns by age, gender, ethnic, and religious affiliation in the host community, and whether the displaced population adapts more to local settings or retains their own cultural individuality. The triple trauma paradigm is theorized as being at least a part explanation of why trauma and social stresses may lead to the development of substance use disorder, particularly among forcibly displaced populations. Epidemiological data of prevalence of substance use disorder, however, are quite scanty at present and subject to methodological limitations. This diagram by Amoro 2021 gives you an idea of the complexity involved when you try and break down all the different factors and the levels of influence that might in fact impact upon the vulnerability of populations to substance use disorder. They look specifically at the impact of socially toxic environments, discrimination, and racism that these forcibly displaced populations may encounter in their countries of origin or into their host countries. This diagram translates a lot of the information that we have seen so far into a more specific situation relating to forcibly displaced populations. It is based on a literature review that we conducted, a scoping review, which shows the different levels where factors act at the micro, meso, and macro level, and 4 quadrants, which you will see in more detail in a diagram shortly, which identifies factors such as loss of neighbors, family, gender roles, identity, trauma related to deprivation, war, violence, acculturation related to the extent to which individuals and populations can retain their own cultural identity or indeed normalize their cultural identity within their new host countries. And then finally, dangers during transit, both when they leave the country, but also when they settle in the host country or potentially return. Here then we get some idea of exactly how complex all these interactions could be. Looking at the yellow quadrant, we see loss and insecurity. In the purple quadrant, trauma and violence, acculturation in the off-green, and in the blue, transit and resettlement, all of which centers around increasing vulnerability towards substance use disorder. The blue lines are positively reinforcing effects, in other words, increasing the impact of certain factors on the individual, and the red lines are negative reinforcing factors. The message I hope I'm getting across at this point is that it is a complex picture, and no one way of actually exploring this problem will work or give us sufficiently clear ideas or indication as to how to manage it. Equally, there are no shortcuts or simple solutions. CORT 2022 attempted to provide a framework for how we not only understand the implications of a syndemic approach, but also some practical steps to actually produce policies that might help to reduce syndemic effects. Firstly, by way of trying to put the puzzle pieces together to map the context underpinning the health issues that a forcibly displaced population faces, they suggest that it is important to map not only the differential distribution of health problems, but also the regional and local differences in political, structural, and historical determinants of health. They suggest also looking at the clustering of multimorbidities and tracking these alongside infectious diseases and malnutrition information, as well as mental health and other non-communicable disease epidemiology. Alongside this, they suggest overlapping this information with human rights documentation of political violence, exposure to sexual and physical violence, and experiences of trauma and displacement. Once you have an idea of what the picture looks like, you can then go on to identify opportunities of how to actually improve things. They suggest upstream community-based political interventions during and after humanitarian crises to mitigate the drivers of health differentials or inequality. For example, tackling discrimination at school and community level, ensuring safe elections and peaceful transfers of power, providing medical care not only to displaced persons, but also to underserved and politically insecure locations within both the target country and the host country, address violence related to law enforcement and security personnel in humanitarian emergencies, and ensuring voting rights and female literacy. They also strongly advise collaborative approaches, just as it is impossible to understand syndemics without accounting for historical and current inequities and the nature of the political violence at hand. Solutions can also not be achieved without working in partnership with the communities that constitute these institutions, structures, and social relations. Collaborative approaches are needed to transform structures, institutions, processes to respond at the level of social, political, and economic determinants with upstream and political interventions. I conclude, therefore, by saying that syndemic approaches are certainly not simple, nor are they straightforward, nor are they linear. In fact, if anything, all you will get from all of this is huge amounts of complexity and very challenging policy approaches and policy recommendations. However, in the context of very complex problems, we should not be expecting simple solutions. Thank you.